chronic hepatitis B viral infection. If you're going to look into the data in India, almost around 40 million people are being chronically infected. And if you're always, you need to scrutinize the patient. Around 1 to 5% of the population can go for cirrhotic and other complications. And there may be high possibility for these patients to land up in dangerous liver cancer, nothing but hepatocellular carcinoma. And around 20 to 30% of the cirrhotic patients in the background of hepatitis B are being reported in India. So look into this risk factors as we are well known. So it's mainly, which is being transmitted by a percutaneous modality of spread. So by any modality, it could be by blood transfusion or sexual workers, or by male-to-male sex partners, or by prisoners or migrants, or women, patients who are going to have hemodialysis, or the patient is going to be having a immunocompromised state. These are all the various risk factors, and always you need to look into that, which is the predominant area you're going to focus. If you're going to focus a chronic hepatitis B, we need to look for other coexisting viral infections like hepatitis C virus or HIV, all the possible events to be addressed factors. And once any patient hepatitis B, we need to scrutinize the entire family member, and we need to look for the family mothers, siblings, spouses, children, any other family members being affected with this event, all those things to be addressed. And based upon that, you have a national viral hepatitis control program has to be initiated successfully. And if you're going to look into this, most of the events, right from starting from perinatal period, there may be high possibility for this. Around 90 to 95% of the population can go for chronicity. Once the patient is going for chronicity, there is high possibility for this kind of patient to land up with cirrhotic background, and there may be high possibility for this kind of patients to go for hepatocellular carcinoma. So what is the present scenario? So we need to look for this event, whether it is happening, because if you want to diagnose hepatitis B, there are newer markers out there. As you all know that it's still, because our intention is only to cover the basic area. Before you're going to wind up this session of hepatitis B, you need to know something about how are you going to do the basic serological markers, and what are the basic antiviral drugs are available. And if you're going to initiate a treatment, how are you going to monitor the patient with antivirals? All those things, basic need has to be addressed properly if you want to look into this scenario. And so diagnostic and treatment services have so far been well available throughout the private sector as well as in government sector in India. So if you're going to look into this, our target is mainly, we need to control the viral hepatitis, and we need to have a good prevention program, and we need to do a good surveillance and good screening and counseling, treatment most of the time as per the National Viral Hepatitis Control Program. Now the has been by our target should be by, I think I'm very clear right now, by 2030, by 2030, we need to eliminate, we need to eradicate, but whether it is possible, whether it is, all those things, whether it is mission possible or mission impossible, that has to be addressed properly. Target this National Viral Hepatitis Control Program. So our aim, we need to combat this viral hepatitis by 2030. Other complications to be scrutinized properly, and we need to reduce the morbidity. If you don't mind, can you mute other persons? So kindly mute, sir, because it's distracting. So other persons, please kindly mute when we are presenting, sir. Then it will not be disturbing for anyone. So it will reduce the morbidity and mortality due to other coexisting viruses like A and E. If you're going to do a proper surveillance, and we are going to do a proper treatment regimen protocol, if it is going to be initiated. As we all know that this hepatitis B virus, if you're going to look into the structure, it's nothing but a double-stranded DNA virus. It's also called as hep adenovirus. That's mainly based upon the main thing. One is because of two enzymes. One is because of the reverse transcriptase, and another one is because of the ribonuclease pathway. All those things is going to be activated. And see, if you're going, see, my slide for life cycle is not being there, but briefly I'll be telling you about the life cycle. Once the virus get into the receptors by receptor-mediated endocytotic pathway, it will be adhering to NTCP, nothing but sodium charocholate peptide, and from that it is going to get into the nucleus. From there into the cytoplasm. There are so much of new molecules, so much of advent has been happened in this hepatitis B virus. Discovery is still questionable, and there's still a wonderful imaginary trigger which is happening right now, how to target this hepatitis B, and so many new molecules being studied for that, which has been trialed in various leading centers throughout India. So if you're going to look into the data, perinatal transmission is the most commonly reported, and one of the, high prevalence area as well. Other sexual contact and percutaneous mode of transmission also going to contribute in this. Simple phenomena, the clinical presentation, it can be, as I discussed with you in initial phase, it can be a acute event. My voice is audible, sir? Whether my voice is audible, sir? I'm not breaking now.
Yes, sir. Audible, sir. Audible.
Yes, sir. Yes, sir. Thank you, sir. So it can be because of acute event, or it could be because of chronic event. If you're going to look into the acute, it's very simple. It can predispose to anictic phase, to icteric phase of hepatitis. Once a patient is going for hepatic phase, you may land up with fever, nausea, vomiting. All those basic virological symptoms can be there. Sometimes a rash and other presentation can also be reported. If you're going to be, always the incubation period will be, it can go up to 180 days, up to 6 months of period. But once a patient is going for chronicity, that is the area which will be very tough to understand, because once a patient is going for chronicity from asymptomatic to chronic and then progressing to cirrhosis and hepatocellular carcinoma, how are you going to monitor the patient, whether this patient is progressing, but this patient remains static, whether this patient is incidentally detected, no other complication. These are all the various phenomena. First, we should understand. First, we should try to understand all the concepts, followed by we can able to manage this clinical scenario, this complication successfully. So what is this acute hepatitis? Because approximately 70% of the population may be having a subclinical or anictic, but around 30% can go for a clinical icteric hepatitis focus. So fulminant hepatitis B in acute hepatitis can happen in around 0.5 to 1% of the population, but it's mainly due to a massive immune-mediated lysis, nothing but of infected hepatocytes. Once the hepatocyte has been infected by proper exocytotic pathway, this NIC virus is going to get released massively, followed by it may predispose to a massive immune-mediated lysis, a T-cell dependent pathway. All those things is going to get activated, followed by the patient may land up with acute hepatitis, and you may also develop a serum sickness like phenomena that what I've been discussed with you as the initial constitutional symptoms may be reported if the patient is going to land up with acute hepatitis B. So most of the patient doesn't deserve any management. If the patient, see, always remember few points before winding up my presentation. In the background of acute hepatitis B, most of the time, like other viral hepatitis, no need to treat the patient with any antiviral support. But there are certain pointers, there are certain indications. You should remember that once the patient's bilirubin, if it is going to be more than 3 to 5, and if the patient's INR, that means that the patient is going for liver failure. If the patient's INR, if it is going to be more than 1.5, in the background of hepatic NCAF or in the background of ascitic presentation, there is high possibility for you to consider this patient on antiviral support, either with a high potent antiviral like Tenofovir or Entecavir. These kind of molecules you can initiate if you're going to manage a patient with acute hepatitis B who is going for a worsening of events. So 90% usually by a perinatally acquired infection, and 20 to 50% of the infection, but usually by the age of around 1 to 5 years, and less than 5% will be a adult acquired infection. So if the patient is getting infection in the adulthood period, is usually will be less than 5%. As I discussed with you, the treatment will be in acute hepatitis B. See the clinical presentation and manage the patient conservatively. Look for any other complications. If the patient is having coagulopathy, that what have been discussed, manage accordingly. Deeply jaundice, encephalopathy, refer the patient promptly to an IS center and encourage oral fluids, discourage native medications, and followed by look for any other precipitating events. Always, if you are going to diagnose a viral hepatitis, don't think that it's only because of B or D. It could be a coexisting hepatitis E or A or E also can supervene in that, or it could be because of reactivation of previously existing virus. All those things has to be analyzed properly if you want to manage a patient with acute hepatitis B promptly. Next to that, briefly about the chronic hepatitis B, if you're going to look into that, the main thing, there are multiple prevalence area, because if you're looking for the Asian continent, it will be approximately 30 to 50% will be chronic. Have a past history of acute hepatitis will be the usual presentation. Mode of onset will be predominantly by a perinatal. That's what I've been discussed with you. If you're going to look into this, once the patient is going for chronicity, as we all know, right from your basic knowledge, when you're going to brush up in that, right from chronic liver disease, as we are discussing, right from your head to foot, you need to look for all the stigmata for chronic liver disease, right? It could be because of jaundice, splenomegaly, ascites. You may have volume overload status. You may present with UGA bleed, and you may land up with encephalopathy. These are all the pointers that the patient is going for evidence of acute liver failure. There is some possibility, and also you need to do a virological screening along with you need to do a tumor marker assessment. Even then, there are newer tumor markers are still there. Alpha fetoprotein, serial monitoring has to be done. And if the level of it is going to be more than 1,000, it shows a very significant pointer that this patient is going to be land up with evidence of hepatocellular cancer. And always in the background of anemia, look for possibility in the background of chronic liver disease. You need to rule out hypersplenism. And once phenomena, and once the patient is having hypoalbuminemia, you need to look for GI.
Hello. Sir, audio break, sir. Slides break, sir.
Sorry for the interruption. I think maybe the presenter get ready for that. Meanwhile, there will be all slides will be shared.
Now I am there, sir.
Yes, yes, sir.
Now I am there, sir. Can you able to see my slides, sir?
Yes, sir.
Can you able to see my
We are
slides?
able to see. Yes, sir. Good morning, Dr. Arun.
I'm sorry, sir. I'm sorry for the break. Probably some misconnection has been happened. Okay, sir.
Please
so, shall I proceed, sir? So, if you're going to look into this natural course and phase of chronic hepatitis B, it's very one tough entity to understand about this pathophysiological event, what is going to happen if you're going to look for this chronic hepatitis B. What is the natural event? If you're going to look into this, there is one complex area, what is called as cccDNA. That means covalently closed circular DNA. It is one of the very complex event to get target if you're going to manage this viral hepatitis B completely. And if you're going to look into this, two areas to tackle this chronic hepatitis B. One is by functional cure and one is by virological cure. What is this functional cure? Once a patient becomes HBsAg positive, and if you're going to treat the patient for that, followed by the HBsAg if it is going to get negative, and your HBV DNA if it is going to come down, which means that no target has been detected, that shows evidence of some functional cure for the patient. This is what the recent definition been given in various guidelines. What is this virological cure? Virological cure is nothing but your B positive status has to come down and your HBV DNA target should not be detected, followed by your cccDNA also should not be detected. If you're going to look for all those things, which means a complete sterile virological cure has happened. So what is this natural event of this chronic hepatitis B? The initial phase, what you have been discussed, like immune active, immune tolerant, inactive phase, immune escape, that reactivation, all those phenomena now, it's not much in use. Nowadays, we need to categorize the patient mainly whether it is by hepatitis E antigen positivity is there or not. So how are you going to categorize? I didn't put that slide, but I will talk on that. But first, you should see whether the patient be HBeAg positive. Once the patient becomes HBsAg positive, then look for HBeAg. If the patient is going to have HBeAg positive status, look for whether the patient is having evidence of HBeAg positive chronic infection or whether the patient is having evidence of HBeAg positive chronic Hep B. Once, see, this chronic infection is nothing but the first phase, what we call as immune tolerance phase. In this phase, your HBsAg levels will be high, your DNA levels will be high, if it will be more than 10^7 log, and your ALT may be normal, your liver diseases will be minimal, and then you are going to be in your immune tolerant phase. But once you are going to be in phase of HBeAg positive with chronic hepatitis B, that shows evidence of your HBsAg levels will be going high, 10^4 to 10^7 of DNA may be there, followed by your ALT levels will also be high, and liver disease may be going for moderate to severe phenomena. So in this phase, there's nothing but immune reactivation is going to get happen, followed by you are going to land up with moderate to severe liver disease once you're going to land up with HBeAg positive chronic Hep B. And what is the other clinical scenario? The same thing with HBeAg negative background. So HBeAg becomes negative, and either it could be because of chronic Hep B infection or you're going to have chronic hepatitis B only. So Hep B infection means your HBsAg is going to come down, your DNA will be less than 2000, your ALT values, always you should see your DNA values, your virological values. I mean, along with that, you need to see your histological pointers, your fibrotic index. You need to look for biochemical parameters like your ALT, and you need to look for your, these are all the parameters if you want to monitor all these things to be analyzed, your histology, your virological, your serological, all those pointers to be analyzed properly if you're going to manage, if you want to look into this natural history of this hepatitis B. And HBsAg chronic Hep B, in this phase, either you can go for the moderate to severe liver injury. And once the patient is going for HBs completely becomes negative, it shows evidence that the patient is going for a resolved hepatitis B virus infection, which means your HBsAg is becoming negative, your DNA will be undetectable, ALT levels is going to become normal, your liver disease will be a minimum 1 or none. So which makes clear point that the patient is going for HBsAg negative phase. So this is how we define the various phases of this chronic hepatitis B to brush up with the basic knowledge. What we are supposed to remember, always you need to see whether the patient is going to land up with HBeAg positivity or negativity, whether the patient is having evidence of infection or chronicity. So you need to see infection or inflammation, which one of this basic event is being active, followed by you need to manage this scenario. How are you going to resolve? I mean, usually resolution, which means HBsAg, once the patient becomes positive, or if the patient wants to become negative, resolution of hepatitis B will be an uncommon scenario, very, very rare presentation. Around 0.5 to 1% of the population can report this HBsAg may become negative due to your clearance of your virus, but always, even then, you need to monitor this kind of patients also for risk of progression for other major dreadful complications like liver cell cancer or other things to get progress. So, as I discussed with you, the baseline parameters, the evidence of liver failure parameters, your serological parameters, your fibrotic index, your liver function test, your ALT measurement, and you need to look for all those parameters to categorize the patient for with evidence of chronic HB. And serological markers, your DNA levels, as I discussed with you, your severity of liver disease, your liver enzymes, and now the fibroscan has been taken a very clear load. What is it? Basic thing you need to remember, if you're going to do a transient elastography, nothing but if you're going to do your fibroscan, and if the value, if it is going to be more than 11, that shows a very clear pointer that the patient is going to land up with evidence of cirrhosis, and the target should be less than 6. That's what the most important thing. And liver biopsy can be done if available, only in resource available settings can be tried if you want to go for liver biopsy. So serological markers, various markers, the basic thing, HBsAg, HBV, HBeAg, anti-HBC total to look for your ACL phase, and also you need to do your hepatitis B viral DNA levels, all those things to be analyzed if you want to monitor, if you want to manage a patient with chronic HB scenario. And as I discussed with you, how are you going to monitor this level? Suppose if the patient doesn't have any events, if the patient is stable, if the patient HBV DNA is less, but the ALT is borderline, all that, there are various, if you're going to look into this hepatitis B virus, there are more than 500 varied clinical scenarios are there. And it's not very easy to understand all the phenomena in single day. But if you're going to look into that, more than varied parameters, the common clinical scenario, what we are facing is, once the patient is going for chronicity, once the patient is going for cirrhosis or compensated or decompensated, if you are going to be in the initial phase of management, better start the patient on antiviral support. And next to that, once the patient is going to be incidentally detected asymptomatic hepatitis B virus positivity, analyze, see, monitor the patient, serial monitoring, look for, as I discussed with you, a serological parameter, your virological event, your histological parameters, biochemical parameters, all those things you need to analyze properly to have a look on this hepatitis B virus promptly. And as I discussed with you, the assessment of severity by multiple other scenario, sometimes your tumor markers also, alpha-fetoprotein serially, once a patient gone for chronicity, every 6 months once you need to do an alpha-fetoprotein assessment also, and all those pointers, if you are going to look into that, if your DNA, see what are the various indications, various guidelines have been mentioned, various indications, but always you remember that if you're in the background of compensated or decompensated cirrhosis, even with any DNA values, if the ALT is going to be in a significantly minimal higher range, what is the normal cutoff of ALT? What they've been mentioned in that there are various guidelines for this ALT measurement, but if it is going to be more than 30 to 40, that is pointer for you to consider this patient to be initiated on antiviral support, along with if your DNA, if it is going to be more than 2000 in the background of pregnancy, the DNA value should be slightly higher than that. All these things to be analyzed. And once a patient is going for chronicity, if your patient is going for immunocompromised phase, all those things to be pointed out promptly before considering this patient to be started on antiviral support. This is all the basic things. Age more than 30 years, if the DNA, if it is going to be more than 20,000, but persistently normal ALT, so we can always wait and monitor this kind of patients. But once a patient's ALT is slightly in the higher side, if your fibroscan is worsening, even if your DNA is slightly in the lower side, so always you need to monitor this kind of patients. But whom to treat? Always the compensated or decompensated phase of cirrhosis, you need to monitor and you need to initiate the treatment. This is what the initial guidelines by AASLD, what they mentioned in that. So if the patient is not going to be HBeAg positive patient, what is it supposed to do? Look for ALT levels. If it is going to be more than 2 times of the upper limit of normal, and your HBV DNA, if it is going to be 20,000 in the background of HBeAg, what you're supposed to do, if there is concern, you need to initiate the patient on treatment. And once the patient HBV DNA, if it is coming down, and if the HBV DNA, if the virological load, if it is going to... So at that point of time, you can always wait, watch, and monitor. And this is all the initial schematic guidelines based upon your APASL, based upon your ASLD. So many guidelines are there. That's not my indication. That's not my area to talk about that right now. But my thing, what is supposed to remember, look for DNA, look for ALD, assess a clinical pointer, fibroscan measurement, and followed by design the patient with your own protocol, what is needed for this thing to initiate the patient with chronic hepatitis B regimen. And for children, it's a separate protocol is there, and these are all the various drugs available right now for Tenofovir as well as Entecavir. I think the voice is kindly mute. Kindly mute, sir. The other person, please kindly mute. I don't want this interruption, sir. Please kindly mute, sir. Thank you. And if you're going to look into these various drug regimens, predominantly, if you're going to manage a pediatric patient, the initial drug will be interferon-based regimen. But once a patient is being considering for adulthood, either you can consider with the Tenofovir in the background of pregnancy and other things, or you can also consider the patient with Entecavir. So many newer drug molecules also can be added, but this basic two molecules can be considered in the armamentarium if you are going to manage a patient with chronic hepatitis B. The selection of antiviral based upon your clinical presentation, based upon your comorbidities, if you are having renal injury, renal complications, now the newer molecules like Tenofovir alafenamide can be considered. And if you are going to be having resistance, what do you mean by this resistance? If you are going to have ALT, if it is not going to come down, if it is more than 3 months of therapy, more than 1 log of reduction is not going to get happen, followed by there is point of for you to have a resistance to the basic molecule. And that point of juncture, you may consider a change of regimen. You need to switch over your antiviral, and this is how the basic guidelines. And now Entecavir even up to more than 2-3 initial most of the studies being done in the age group of adolescent period. But now what they may mention even in the age group of 2 to 11 can be considered, but you need to monitor the patient whether the patient is worsening or not following the initiation of antiviral support. So Entecavir can be preferred over Tenofovir if the patient is going to have osteoporotic changes, if the patient is old age, and if the patient is having altered renal function. So those are all the parameters you can consider. And always Tenofovir alafenamide can be considered if the patient is going to have reduced renal functions, or if there's severe bone injury or bone toxicity, if it is going to happen. And always you should remember in acute hepatitis B, interferon not supposed to use, and when to stop treatment once the patient HBV DNA becomes undetectable and your HBsAg is not going to become positive at any point of time. There might be evidence of seroconversion and anti-HBs is going to get appear. That shows evidence in the background of no histological worsening, or your APRI score, if it is going to be more than, see, APRI is nothing but AST to platelet ratio index, which shows a clear pointer. If it is going to be more than 2, that shows evidence of cirrhotic background. If all those things is not there, once a patient is having complete virological response, nowadays even the newer markers like HBV RNA to look for evidence of close covalently circular loops, all those things, if you want to analyze, then you can continue or discontinue this kind of patients who are on the treatment with chronic Hep B. And there are various scenarios based upon your clinical doubts. I can address those things. And discontinuation may be considered in patient without cirrhosis. Always you should remember no cirrhosis. Always you need to see serial monitoring, your seroconversion of your HBeAg to anti-HBe, and with persistent in various levels for around a period of 1 year of consolidated treatment. If the persistent HBsAg, if it is not going to appear, it's persistent loss of HBsAg, then you can discontinue this patient on antiviral support. So always once a patient been discontinued, there may be evidence of reactivation or relapse. What is this anti-HBc? Total may become positive. Your DNA levels may go high in the background of any immunocompromised status. That shows evidence of your HBV reactivation phase. At that point of juncture, the patient may land up with evidence of acute hepatitis in the background of chronic event. So you need to tackle all those problems promptly to overcome all these complications. So monitoring is the most important phenomena. Monitoring, your drug monitoring, your serological, histological monitoring, all the various parameters over a period of 3 months, 6 months, 9 months, and 12 months of duration. Lifelong monitoring is the most important for you to tackle this chronic Hep B if the patient is going for chronicity. So not on treatment, always you should remember that. So monitoring not on treatment means you need to do a serial ALT, HBAG, and look for evidence of DNA around 6 months to 12 months period. And once a patient is going for active phase, which means inactive chronic HB with persistently normal ALT and DNA, and if it is going to be less than 20,000, this kind of patients also can be monitored every year once, whether the patient is having worsening of ALT and other events to progress. So most frequently 3 to 6 months once monitoring, as I discussed with you, the treatment discontinuation, and there are so many other non-invasive pointers for you to assess, and that's how you need to manage a patient with this Tenofovir and Entecavir based upon the various dosage regimens, and monitoring the patient with hepatocellular cancer, whether the patient is progressing or not. Look for evidence of alpha fetoprotein every 6 months once. You do an imaging assessment, look for ultrasound. It's a basic parameter to screen, and if you have any suspicion of SOL, the space occupying lesion is there, then that is high pointer for you to go for a CT screening, triple phase CT assessment, all those things. Once the patient is pregnant, always the ideal molecule to consider for Tenofovir. But when to initiate the patient, if it is going to be more than 2 lakhs of regimen of DNA copies, then there is pointer for you to consider at the duration of around 28 to 30 weeks of gestation. And make sure you need to give the newborn baby hepatitis B immunoglobulin, along with you initiate as per the national immunization program, hepatitis B virus vaccinations to be given at a dosage of around 0, 1, and 6 months to be initiated promptly, along with your HBE, HBI immunoglobulin in the background of around 0.5 ml in the opposite limb to be considered if the patient is going to be pregnant and followed by for the newborn baby. This is how the treatment regimen has to be established. So that's what I've been discussing about this hepatitis B immunoglobulin for newborn babies. And breastfeeding, absolutely no contraindication if you're going to look into the scenario, unless and otherwise, if the mother is not going to present with evidence of a massive nipple injury like a cracked nipple or other sore nipple or breast abscess or anything else. Apart from that, no major contraindication for a baby to get breastfed in the background of chronic HB if the mother is on antiviral support. So timely testing, newborn assessment, and prompt initiation of antiviral like Tenofovir to the pregnant woman. That's the most important thing to overcome the pregnancy-related complication. But HIV and HBV co-infection, you need to target HIV and you need to target hepatitis B virus also, because this kind of patients will be immunocompromised. So most of the time, the reactivation of this hepatitis B can happen around 8 to 12 weeks of treatment of your initial phase of HIV. So what you're supposed to do, serial monitoring of DNA, ALT levels, liver function, all those things has to be answered. You need to choose a molecule which targets both HIV as well as hepatitis B. Either you need to start the patient on Tenofovir-based regimen, regardless of your CD4 count, and you need to initiate, and serial monitoring has to be done. And usually, faster CD4 decline, as slower CD4 recovery, increased incidence of HIV and other complications like AIDS. All these problems, once a patient been infected with coexisting hepatitis B or C, can report. So you need to monitor these kind of patients very promptly to overcome this HIV and HBV related coexisting complications. So next to that, as I discussed with you, serial monitoring to assess for progression in HIV, HBV co-infections. And you need to initiate this treatment regimen like Tenofovir, lamivudine, and efavirenz-based therapy, and assess the patient for prompt DNA suppression, and look for evidence of seroconversion, and look for evidence of HBsAg loss is there or not. So ARV need to be changed because of HIV drug resistance or some drug toxicity. Then Tenofovir and lamivudine should be always continue together unless it's specifically contraindicated. So prevention, always vaccination is one of the most important things. If you're going to be immunocompromised, take double the dose regimen and followed by 4 doses regimen. You can go for immunocompromised phase. Otherwise, 3 doses regimen is recommended. And over the patient, we need to go for hepatitis B. And right now, for the perinatal mode of transmission, right from your newborn period, your vaccination protocol has been well initiated right from your national immunization control program. So hepatitis B vaccination is the most important, not only for the COVID scenario. You should remember that always you should vaccinate for B. And even as medical workers, even as healthcare workers, the staff nurse and other persons, we need to regularly screen. Once you have been infected with this hepatitis B virus population, you need to look for anti-HBs. Once you're anti-HBs, if it is not going to be more than 10, there is high pointer for you to acquire the infection. At that point of junction, you need to go for immunoglobulin support. That's what been most important, and to prevent this hepatitis B virus complication. So before concluding, This hepatitis B virus is very complex event to understood and very complex event to understand, followed by, if you want to manage, see whether the patient is having acute hepatitis or see whether the patient is having evidence of chronic hepatitis. Once the patient is going to land up with acute or chronic, look for evidence of progression like serological monitoring, virological monitoring, and biochemical parameter, your histological parameter, baseline clinical assessment. Your clinical examination is the most important, based upon your endoscopic surveillance, whether the patient is having evidence of portal hypertension or whether the patient is having evidence of chronicity of liver disease. All these pointers to be addressed properly if you want to manage a patient. And there are newer viral entries, newer add-on therapy which is being added in the armamentarium of this antiviral, like entry inhibitors, so many other molecules like replicating markers, your HCV RNA targeting vaccines, so many newer innovative is being happening that I'll be discussing with you all in other slide presentation. And with this, I would like to rest my presentation. I'm happy to take up your questions. Thanking you all for patient listening. Any questions to answer?
I think it will be all nodal officers of the various treatment center who have been